Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior-skull-based surgeon from Winchester and the University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior-skull-based surgery webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So can I request Christos to introduce Thibaut?
Yes, of course.
I'm sorry for the talk.
It's a pleasure. So we have Professor Thibaut Van Zele, a longtime friend. I knew him since he was a resident, I think, which means he's much younger than me. and currently, basically, he's doing a lot of skull-based surgery and oncological surgery recently. But the truth is that when he was younger, his background, and he still is, of course, young, but in any case, he has done a lot of work on biologics. And that's why I think he was asked to discuss the topic, that I think he's one of the team of Professor Klaus Bachert and of course, Philippe Scheffart, that have done incredible amount of work on one of the first on the world in biologicals. So you will be learning from the horse mouth, from the source. So Thibaut, thank you for joining us, and I leave the place to you.
Thank you, Christos and Ashok, for inviting me to this great event, and also for this nice introduction. So indeed, when I was younger, but not so much younger, I worked especially on the endotyping of chronic sinusitis and nasal polyps. And I'm very happy to see that the work that we have done 10, 15 years ago is now coming into clinical practice with the biologicals. And I will try to give you an overview of what is currently known, but also unknown about biologicals. I think the biologicals are here to stay, and we have to adapt all the knowledge associated with these biologicals, and I think they will change our practice, although not dramatically. Now, the reason why biologicals were developed is that there are clear unmet needs for chronic sinusitis with nasal polyps. We know that systemic corticosteroids have an effect on nasal polyps, but of course the duration of the effect is quite limited. If you see here, this was a placebo-controlled trial with plus methylprednisolone and also doxycycline, where we gave the methylprednisolone for 20 days. And when actually the dose was tapered, we already saw that the nasal polyps were coming back. And at the end of the trial, at 12 weeks, there was really no difference compared to the baseline, to the start of the treatment. So corticosteroids, they do work, but they have a short duration of effect, and also they have considerable side effects. Also with local corticosteroids, there are some issues, especially with the sprays, because they have limited access to the sinuses and also to where the disease progress is going on. We try to solve this by using lavages, as told by Richard Harvey in the previous talks, with some good results. And the third problem we have is with surgery. We know that sinus surgery is a good treatment option for chronic sinusitis with polyps if it is combined also with continuous postoperative treatment with local corticosteroids. But there is in fact a small group of patients which have a poor outcome also after surgery. This is a 12-year follow-up study of our patients that had surgery in the year 2000, and we followed them up for 6 years up to 12 years. And what we saw that at 12 years, 40% of the patients had no polyp recurrence, 40% had a recurrence but of rather small polyps, and then you had a group of about 20% which had grade 3 to 4 and 5 to 6 polyps combined on both sides. And also, this was the group that needed revision surgery, and this is also the group that will need multiple sinus surgeries to control their disease. And I think we are focusing for the biologicals on this group. So as was told before this morning, we now see that the EPOS guideline of 2020 has adopted the concept of endotyping. So we are not only talking about chronic sinusitis with or without polyps, but now we are also adding the endotype, so the background inflammatory process on the disease categorization. So we are now speaking about an endotype dominance of type 2 and non-type 2, and I will show you where this type 2 and non-type 2 is coming from. So in 2006, this one was one of our first studies where we just looked at the inflammatory mediators which were present in nasal polyp tissue, and we could show that nasal polyps have a high influx of eosinophils. They have quite high levels locally of IL-5, and also they have local high levels of IgE. And we also could show that this was due to high plasma cells that locally produce the IgE. Here we showed that the IL-5 was produced by the T helper 2 cells, and this is really pointing towards this type 2 inflammatory process, or this type 2 disease. A few years later, we did a large trial or a large study in Europe with 10 centers. And this was under the umbrella of the Galen network, where we endotyped all patients with chronic sinusitis with or without polyps, and we looked at 9 inflammatory mediators in the tissue. Without the background knowledge of if there were polyps present or not, we used a statistical test to make categories, and what we observed was that we had in the beginning 2 big categories, which were IL-5 negative patients, and another category which had IL-5 present. And what we observed, and we then looked at the phenotype, we saw that in the IL-5 negative group, there were much more patients without polyps, and also these patients rarely had asthma, but when the inflammation shifted towards a clear type 2 inflammation with high IL-5, high IgE and high ECP levels, we had significantly more patients with nasal polyps, up to 100%, and also the presence of asthma went up to 70%. So what do we have to remember of this endotyping, especially when we will later on look at the biologicals, is that we have a non-type 2 chronic sinusitis. Most of them will be patients without polyps, so they will have a low risk of asthma, and also if you do surgery, they will have a low risk of recurrence. We have a group in between, which is a moderate type 2, which is a mixed population of chronic sinusitis with or without polyps. There is already an increased asthma risk, but it's between 10 and 40%, and even surgery and also good postoperative treatment can have a good outcome in these patients with a moderate risk of recurrence of disease. And then we have the severe type 2 disease, which is almost exclusively patients with chronic sinusitis with polyps. They have a high prevalence of asthma, up to 70%, and also the recurrence risk after adequate surgical and medical treatment is high. And how do we define for a clinician without, let's say, a basic immunology laboratory next to his office at this type 2 disease? Well, you can look at it with counting blood eosinophils. So when the blood eosinophils are higher than 300 per microliter, high total serum IgE levels is a marker for the type 2 immune response. The presence of IgE to endotoxins, lower airway biomarkers, and increased serum prelosteum levels. So you clearly see that in this small group of patients with chronic sinusitis, we have a problem with a very strong type 2 inflammatory response. And if you look at this diagram, you see the pathway of a type 2 inflammatory reaction. And we see that we have the IL-5 produced by Th2 cell driving eosinophilic inflammation. Also, IL-4 is doing that together with IgE production. We have IL-9, which stimulates mast cells. And you can easily think about blocking these cytokines and IgE to lower this inflammatory reaction. So there was a recent development of a lot of biologicals. If you look at this time frame, you see that corticosteroids were developed in the 1950s. Then we had the discovery of IgE in 70, and then it took about 30 years before an anti-IgE molecule was developed. And you see that in the 90s and the 20s, we learned a lot about cytokines, and we also found these cytokines back in this polyp tissue. And then about 10 to 20 years later, we see that here in the last decade, there are a lot of monoclonal antibodies produced, like mepolizumab, veslizumab, benralizumab, and dupilumab. Those four we have to remember. So now I will show you the clinical trials that have been performed, so phase 2 and phase 3 studies with these monoclonal antibodies. The first group are the monoclonal antibodies directed against anti-IL-5. Here you see a immunohistochemical picture of a nasal polyps, where you see all these red dots representing an eosinophil. So we know that if we will administer anti-IL-5, it will block the IL-5 function, which stimulates eosinophils. It stimulates eosinophil production, maturation, but also the release of granules like ECP and MBP, EPO and EDN, and also cytokines. So anti-IL-5 is really directed as an anti-eosinophilic treatment. And this was the first proof of concept study with rather small groups. So there were about 20 patients in both groups, in the placebo group and in the treated group. The patients got only 2 injections of 700 milligrams of mepolizumab, which is anti-IL-5. And here we looked at the improvement in nasal polyp score. So we used the Davos score, and you see that with 2 injections after 8 weeks, you have a significant but not that tremendous decrease in nasal polyp score. But we also have seen that there were clear responders and non-responders in this group. So if you look at the responders, they clearly had a much better improvement in nasal polyps score. Later on, we performed a larger study where about 50 patients in the placebo and the mepolizumab group got 6 doses of mepolizumab, and here we could see that after 6 doses, we got a much better improvement in the total nasal endoscopic score, and also we got a significant improvement in the SNOT-22 score. One of the outcomes was also if mepolizumab could prevent the need for surgery in this group with severe nasal polyposis, and this is seen on this graph. And you see that the percentage of patients in the need of surgery was significantly lower in the group with mepolizumab at the end of the trial at week 25. The second monoclonal antibody is directed to IgE. The anti-IgE drug called omalizumab or Xolair commercially is able to bind to the free IgE, which then prevents mast cell degranulation and immediate release. It's a drug that has been used for a long time in asthma, and it was also due to this knowledge that patients with asthma treated with omalizumab also got an improvement in the nasal polyp symptoms, that this drug was also investigated for nasal polyps. And one of the background reasons was that in nasal polyps we have a clear local production of IgE. So here we see a immunohistochemical picture of plasma cells which are colored in green, and also the red dots represent the IgE molecules locally produced in the nasal polyps. This was the first trial we did. It was a phase 2 study with also a limited group of patients. It was a proof of concept study where the patients got 4 injections of omalizumab based on the serum IgE levels, and they were followed up for 16 weeks. So just like with the anti-IL-5 treatment, we could also show that omalizumab reduced the nasal polyp score significantly up to 16 weeks by 2 scores on the Davos scale. Later on, there was a phase 2 trial, and this was published recently in 2020, where there was a larger group of patients receiving omalizumab. In one trial, it was every 2 weeks, and in the other one, it was every 4 weeks. Important to know is that in both groups, so the patients were continuously treated also with intranasal corticosteroids, so with mometasone twice daily, 2 sprays as a background treatment. And what we saw in this study was that, as expected, in the group treated with omalizumab, we got a significant decrease in the polyp score from compared to baseline. And also, if we look at the upset smell test, we got a significant improvement of the smell by using an upset smell test. Then the last group, or the last target, is anti-IL-4, anti-IL-13 treatment, which is called dupilumab, and it's commercially available under the name of Dupixent. We know that IL-4 and IL-13 play a central role in the type 2 inflammatory response. We know that they, let's say, switch the B cell and plasma cells from IgM to IgE production. They have an influence on the mucus production, they have an influence on airway remodeling, and also they have an influence on airway recruitment of eosinophils. So if you would look at the cascade of inflammation, I think IL-4 and IL-13 play a very central role and have, I think, the most broad effect on the type 2 inflammation. And these are the results from a phase 3 trial with dupilumab. You have in this side of the graph, you see the sinus 24 study where patients were treated with dupilumab for 24 weeks. Every 2 weeks, they got an injection of 300 milligram dupilumab subcutaneously, and then the treatment was stopped, and they were followed up for again 24 weeks. And what you see is that when the patients got dupilumab every 2 weeks, we have a significant decrease in nasal polyp score, and when we stop the treatment, again the polyps try to regrow. If you look here at the sinus 52, so that's the other trial, there the patients got the dupilumab every 2 to 4 weeks until week 24, and then the treatment was continued until week 52 with every month 1 injection. And there we see that even when the period in between the injections went up to 1 month, we still got an improvement in the nasal polyp score after 24 weeks. There was also a significant improvement in nasal obstruction, while in the study where the treatment was stopped, we got again after 2 months an increase in nasal obstruction. And this was the effect of the dupilumab on the Lund-Mackay CT score. So the patients were scanned with CT scans also during this trial. We got a significant decrease in the Lund-Mackay score at week 24, but also in the study where we got the longer dosage of the dupilumab, we also saw a significant improvement in the Lund-Mackay CT score. And this is an illustration of the effect. So here you have January 2017, before the start of the medication. This was after 6 months, and this was 1 year later. So we see also on CT scans a significant improvement in this Lund-Mackay score. What was also good to see was that dupilumab has a very strong effect on smell. So here also the patients were tested with the upset test, and we see that the smell is improving significantly for the duration of the whole study in the Sinus 52 study. But important to see is that in the study where the treatment was stopped after 6 weeks, after 24 weeks, we got a very quick decrease in the sense of smell. So dupilumab is now the only treatment that has been registered for the indication of nasal polyps. So besides for asthma and atopic dermatitis, so we also have now good safety data. And if you look at these adverse events in this phase 3 trials, you see that there were no significantly more adverse events in the dupilumab group compared to the placebo group. I think the most important was the injection site erythema, which the company is now working on, and the nasopharyngitis, which has been associated with dupilumab. So, which patient is a good candidate for biological? Well, we go back to this type 2 information. If you have a patient in front of you with bilateral nasal polyps, you can use these criteria to define if he is eligible for biologic treatment. On the left side, you see the euphoria, where they still make, let's say, a subdivision between patients who had surgery and no surgery. So they say that if you have 3 criteria of these, like evidence of a type 2 inflammation, need for corticosteroids, significantly impaired quality of life, loss of smell, and a diagnosis of comorbid asthma. If you have 3 with a history of previous surgery, this patient could be a candidate for biologic treatment. If there is no history of surgery, they ask for criteria of this list. And these are the EPOS indications for biologic treatment. So here they make no difference between surgery, previous surgery or not. And here they are a little bit more specific with cutoff points. So if evidence of type 2 inflammation, they say, okay, you have a tissue eosinophil of 10 per high power field, or a blood eosinophil above 250, or an IgE above 100 microgram per milliliter. The need for systemic corticosteroids or a contraindication for systemic corticosteroids, significantly impaired quality of life, they ask for a SNOT 22 above 40, patients with significant loss of smell should be tested with a smell test and a diagnosis of comorbid asthma. So what is the position nowadays for biological? As said before, they will never, in my opinion, replace surgery, but they are an add-on therapy really at the end of the treatment pathway of your chronic sinusitis with nasal polyp. But so far, we still don't know the exact position regarding to extended or sinus surgery. So what do we currently know about biologicals? So we know that type 2 cytokines are expressed in about 80% of the nasal polyp patients. We know that these type 2 cytokines are associated with asthma, the recurrence of the disease after surgery. We have now proof of concept studies in nasal polyps with mepolizumab, omalizumab, and dupilumab. And there also have been successful phase 3 trials published for anti-IL-4/13 and omalizumab. And we know that the registration for dupilumab has been achieved in the United States and in some European countries, and also that both drugs, dupilumab and omalizumab, have been shown to significantly reduce the disease burden in patients with chronic sinusitis and nasal polyps. But there are still some unresolved questions. So we still don't know clearly what biomarkers we should take to predict the response to individual drugs, so how we should select which patients will receive which biologic, whether we will give anti-IL-5, anti-IL-4, or anti-IgE. We also don't know yet when the maximal effect is reached with biologicals. You saw in the study with the dupilumab that the patients were still improving after 52 weeks. Also, what the duration is and the long-term dosing. We also don't know if they can prevent asthma, because this would be a very important outcome in patients with chronic sinusitis with nasal polyps. And also the indications for biologics versus surgery, so if biologics can replace surgery, have not been defined so far. And once registered, and that's, I think in this current economic climate, we have to see what the restrictions from the health authorities will be for the use of biologics in chronic sinusitis, but nasal polyps. So thank you for listening to this presentation, and if there are questions, I'm happy to answer them.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
So thank you, Thibaut. It was excellent. It's a very difficult, newly emerging topic, and it was nice to have it after following Richard's talk. So jointly, it just shows us surgical and medical management. So thank you. I know you're rescheduled your clinic and made time for this with a very short notice. So really appreciate it.
Okay.
Great to
Thank
have you
you.
on board.
Thank you for having me.
Thank you.